when we are doing it before the procedure, then it should be comprehensive, but shouldn't take more than 5 minutes.
So Waqar, our problem
is more than 5 minutes.
Shouldn't take more than 5 minutes. क्योंकि अगर आप आधा घंटे consent पे लगाएंगे तो in that you can do 3 procedures.
So Waqar, the issue here is that in our practice here, almost majority of our patients have not seen us before. They come to the center first time. So we have to explain to them what it is. And
अच्छा दूसरा जो है
so we just did an audit ऐसे ही. We have an audit team. So
we send them by post consent form. So it is with the information leaflet. The information leaflet and consent form people भी काफी detail में लिखा होता है सब कुछ. They have got.
What percentage of them actually read it? Do we know exactly how many of them read it?
A significant number read them. So they do. But when you ask them ना कि have you read that, वो कहते हैं कि most of them say yes ना. तो उसमें ये होता है कि that is the standard now अक्सर ये recommend करते हैं वहाँ पे. So that is one thing you can do, or you can put more information on the actual consent form. Because in the past we used to do generic consent form, which was the same for excision of a lipoma, fixing of a fracture, or ERCP. And nowadays we do procedure-specific consent forms, which you can get hold of. I can send you some if you want.
No, we have our own consent forms, so we don't have. So that's why we were looking at the population we deal with gives us 3 telephone numbers, and when we call them, not a single number is available. So we have some issues of communication. Because we are catering for like all the provinces, so we need to have access to all languages. So language का हम barrier हटा देते हैं. लेकिन the IQ of a lot of those people is at a level where for them to understand what is being told is very difficult. Whereas postal भेजना या उनको दे देना, अब जो पेशेंट आपकी क्लिनिक से आता है उसको तो आपने समझा दिया होगा, but that's a small.
नहीं यार, साथ उसमें भी क्योंकि लाहौर में किस तरह का सर्वे किया था, तो उसमें जो पब्लिक सेक्टर हॉस्पिटल में उनको ही जैसे डॉक्टर वकार ने कहा कि रिटर्न दिया, उसको उनको सुनाया, उसके बाद उनकी अंडरस्टैंडिंग उनके जितने भी उसकी पूछा कि आपको क्या समझ आई है, तो वही बात कि लेस देन 5% वो उनका जवाब डॉक्टर साहब जो करना करते, जो प्राइवेट साइड पे थे उसमें तक एक को समझा के हटे तो साथ ही उनका दूसरा अटेंडेंट 2 बंदे फालतू आ गए, एंड दे स्टार्टिंग फ्रॉम स्क्रैच. तो जो समझाने वाला था, जो नर्स थी समझाने वाली, उसने कहा जी ये इशू है, और वो तकरीबन कोई 100 केसेस पे उसने किया था, ये उसका एमडी का थीसिस उस पे.
दूसरा बात ये था कि जितना भी आप
हमारे ये थोड़ा सा आसान है, we only have one attendant.
If you have a patient,
you can't bring 2 people up. No, only 1 person is allowed.
1 person, 1 ticket.
1 person, 1 ticket. Otherwise, no. Except for children.
If even no matter how comprehensive your information is, if the patient is illiterate, they won't be able to read it.
So this is what we were. I've just shared this because the fact that you've taken consent doesn't mean your patient knows what they're going to do.
No, that's true.
If something happens, because we're very scared to tell them क्या हो सकता है. What is the risk? Can you die of this procedure? Yes, you can die, but you don't say that.
This issue is not just limited to Pakistan or the UK. This happens everywhere. We have elderly patients who will ultimately say, "Doc, do whatever you need." Right? So I don't think an animation type situation is not a bad idea because visual aids are helpful. So but even for complications.
So tell me something.
So we go on the planes and we see these beautiful brochures of the plane crashes and what we're supposed to do. हम सबके सामने पड़ा होता है. We're looking at it. When the emergency landing, nice plane going down, slides coming down. We all know about it. Ultimately, how many of us would actually survive one of those events? The thing is, you have to make an animation. I think as you talked about it, and you have to show one drop of blood. You don't have to show like a stream of blood going through. You show a little cut, which is a perforation, and then you show these are events that can occur. You don't show death. You don't show like a coffin.
That can also
But
be made.
no, but you can
Not
show these
good
things.
images.
But the whole point of the consent process is not to scare the patient out of a procedure. It is to give them meaningful information that they are aware. And we can do that with our words. We can talk to a patient. My first interaction with a fellow 2 years ago with an ERCP consent, I was standing there and she kept going on for 10 minutes. And I walked out and I said, next time let me do the consent. Because she scared the patient so much. So the whole idea is finding that balance. And I think no matter what the IQ level or the education level, you may need multiple videos and realize that, okay, this video is too much for this patient, let's try a simpler version. The problem is real everywhere, but I think the solution is in some form of a mechanism of sort of education that is visual, because verbal is not going to be enough.
So how do you tell somebody in your practice that there is the risk of pancreatitis is 3%?
I say it
So
openly.
what we openly tell them,
You openly tell
we
them.
have this diagram, and I actually draw the picture myself every
Yes.
single time. Yes.
I do the same.
I sit there with the patient, I draw the picture. It like literally takes 3 seconds. Now it's that much practice. Okay? Stomach, diaphragm, liver, pancreas, gallbladder. I tell them this is how we're going to go with the scope. We're going to take a look at the opening where the bile duct and the pancreas opens. We're going to cut that, make that bigger a little bit, then pull the stone out. But because we're close to the pancreas, and what can happen is this can irritate the pancreas and cause the inflammation of the pancreas. Usually very minor, more 90% no problem at all, and very like 1 to 2%. I tell them 1 or 2% may have enough that have to stay in the hospital for a day or two. Sometimes it could be serious, but the risk, I don't say it's going to kill you or it can cause a really bad. Goal is not to really sway them away. Just tell them like it can cause the pancreatitis, inflammation, and some of them really don't even want to listen to you. They say, do what you want to do, but at least draw a picture and tell them. We have actually drawn pictures, like already we have a booklet. We just tear that off, show them. That's what the fellows show them. So just some visualization helps them so much.
No, that's the procedure, right?
Yeah.
My thing was you have a risk of pancreatitis
Yes.
about
So I'll tell you
3%.
my wording for that.
In your center it's 2%, right? But X center it's 10%, 8%.
You just quote yours, what you did, yeah. So you just tell
You
them
quote your own figures.
Yeah, you quote our own.
Now, when you say 10%, the patient actually says, what does that mean?
Yeah, 1 out of 10 people.
1 in 10.
You have
1 in
to
10.
break it
1
down.
in 10. You have to give them a
So when you tell them 1 in 10, that's it, you know.
उसको कहो कि 9 है we're fine. You are the 10.
So the problem is that when you're looking at stats is basically an analyzing group, right? What you're telling him that the chance of anybody getting out of 10 is 1. But for him, it's going to be either 0 or 100%.
Yes.
Oh, that's true.
And I actually use that.
So I usually tell them, I equate it with the risks that you generally face of accidents with cars and things like that in the percentage. That you traveled in a car to my clinic, what was the risk of traveling? You think there was a risk? Can you guarantee you can travel to my house? So there's always a risk in everything. And so when I am explaining the complications, I usually pick up something that's more generally known, and then tell them the risk to hai. There is a risk, and if somebody actually wants to go as far as mortality, then yes, of course, it's very important. If you don't, and the person dies, they say you never do. I asked you if my father would have died.
But I will say that there is an obligation on us to actually mention mortality. And the way that by extension of what Dr. Hassan is saying, what I say is, these are the complications or the risks, and the risk of a severe life-threatening complication, including death, is less than 1%. So you have to put in that, because if you don't, then you're not giving them the truth, because ERCP is associated with mortality, right? So it's all about how you word it. You don't say there's a risk of dying, but you say the risk of a severe complication, including death, which is the ultimate complication.
So it's getting the right balance.
Right.
Yes.
I usually say anything
Between
you do,
scaring your patient
Yeah.
and not informing your patient.
Yeah.
So I think you have to be very careful, and that's something that's important.
and usually what I tell them is like, just like any procedure, any surgery, there is some risk. And I always use the word, walking on the street is a risk
Yes.
too.
I see.
Yeah. So this is what I use. Walking
हमारे
on
यहाँ
the street.
इंसान है, हम कहते हैं कराची में गाड़ी चल पे जो मेरी क्लिनिक में आए हो यार, वो ज़्यादा रिस्की है, इसमें ना कोलन में उससे तो कम रिस्क है OGD और
It
कोलन
is
में.
Yeah, exactly.
If they ask you, can I die from this procedure, then you have to be honest with them. Yes, there is a possibility, but the risk is so 1 in 5,000 or whatever.
आप लोगों को कितना एक्सपीरियंस है कि पेशेंट्स ये सुनने के बाद कितने % पेशेंट जो है डिनाई कर देते हैं? होता है ऐसे कोई पेशेंट के जो है डिनाई कर देते हैं?
और कुछ होते हैं.
कुछ होते हैं और दूसरा ये कि एक
And the ones that say no are the best. That's the best thing that's happened to me. I feel. I'd rather pass it on to somebody else by. Pancreatitis, I don't know which patient of mine is going to get pancreatitis, a severe pancreatitis. Or maybe have a cardiac event when we are doing it. We tell about our procedures, but the sedation and anesthesia, etc.
And other thing what I have noticed is like giving the confidence to the patient that you are in the right place, you are in the right hands. This is matters the most, the way you present the things. And the best way to present the thing is not by standing by the patient. Sitting on a chair beside them. I sit in a garbage can, honestly, every day, like every time, because it's opposite to where the family is sitting. So there are two chairs, patient in the middle, and on the other side. Okay? So I sit there, it's like those 1 minute of sitting, to them seems like you've been there for 15 minutes talking to them. 5 minutes of standing to them looks like 30 seconds of conversation. So it also, like really how you're presenting yourself, with what confidence, and you also tell them, I've been going for 15 years, 16 years. This is what we do day in, day out. Give them a confidence. So that helps a lot.
So I think a point that comes very strongly for you guys is that consent is important. Okay? And you need to inform your patients. And you need to be honest. Your data is not going to be as good as what is being quoted in literature initially. Okay? Just be honest about it.
So sir, adding to your point, in a high flow center like this or somewhere else, standardizing the consent thing is quite difficult, right? So I might present my case in a different way, you will present in a different way, sir will present in a different way. I might mask some information to the patient, right? So with what I was initially telling that we can standardize the consent form so the information is communicated to the patient, to every patient actually. No, I'm not saying I will mark, I'm saying standardize.
What he's saying is, you're taking it to a step further. And maybe, what we will do is we end up doing an animation video and then giving it to him, ask him to watch it and then come and say, you watch that video. This is what we're going to do. Is there anything you want to ask? Anything you didn't understand that way? You don't have to spend that time with you. The only thing was if you show it in a group, then that would be a problem. So individual you can. We're going to try the pictorial thing, cartoons, and then let's see what the result comes back. If it doesn't, then we'll move on to. We'll probably make an animation thing. Another thing that is interesting that we are doing is looking at with one of the psychiatry groups is looking at the impact of colonoscopy on young patients. The effect in terms of their acceptance and also if there is any untoward, especially in the field. So and then because we come from a different, हमारा थोड़ा society is different. Okay? Because the consent is important. that's number 1 point. Okay, it should not be taken lightly. Remember, I keep telling my colleagues, friends, imagine you're doing one of my family members. You don't take a consent properly, you are in trouble. Okay, and you don't tell me honestly what is going on. I find out later. I'll have no problems taking you to the court. So you have to understand that that thing is here. It's not just in America or England. So it depends on who you're thinking. Unfortunately, the poor don't have any right in this country. So we are safe as long as they don't have rights. The day they are given their rights, we all have to wake up.
दो quick बातें. एक consent is never taken, it's given. We don't take consent, patient give consent. We don't take consent, they give it, number one. Number two, it's not a consent, it's mostly a disclosure. It's a disclosure of, as it's been sort of said very categorically, it's like your experience, your center, so it's a disclosure. You're actually opening up to them and informing them of what your practices and what your successes, failures or complications are. So more kind of a disclosure.
Done?
और चाय पीएंगे फर्स्ट कोई काम भी कर लेना
John.